Oxford University Press Higher Education Webinars. And now, Oxford is proud to present Melanie Domenech Rodriguez, Building Blocks of Practice with Diverse Populations, Defining and Distinguishing Cultural Adaptation and Cultural Competence.
So my purpose here today, and I put a picture there because I figured I wasn't sure if you were going to have much of a chance to see me or not, is to define cultural competence, define cultural adaptations, which with a very brief exposure to existing models, but I put some reference in there for those of you that are interested in reading more, and to really distinguish cultural competence and cultural adaptations. For those of you that work with culturally diverse populations and who read and write in these areas, you probably know quite well that the literature is full of terms: culturally sensitive, culturally appropriate, culturally attuned. And for those of us that do science, it becomes very difficult to figure out what all of these things mean. What do they have in common? How are they distinguished from one another? And how do these terms help us understand the state of our science and how we must proceed? So hopefully today we can at least take two of these and really narrow in on them. I would like to put them in the context of a broader goal, which for me is to reduce health disparities by way of mental health services that are equally accessible and beneficial to all members of society. So that's the big goal. It's certainly lofty. It's going to take many, many generations of many of us working really hard to see this happen. But, you know, we got to keep our eye on the prize so we can get there. So one quote that I really love to share when I'm doing talks like this is a quote by Bruce Wampold, which is, "Psychotherapy is a culturally based healing practice." I think it's really easy to forget that. And here we have pictures of different folks who are seen as healers in different times and spaces. The person to the extreme right is a Guatemalan healer. We have a doctor. We have a santera, probably in Cuba, mixing her stuff. And of course we have Jesus, who is a very prominent figure culturally. So it's just a reminder that what we do every day is actually culturally based. In our current cultural context, we really have been focusing on evidence-based psychological practice, which sounds really fancy. I know personally I get very frustrated when we have these new sort of catchphrases and then everybody's using them, and we really work hard to make them as complicated as we can so that we can sound smart and efficient and scientific. And in effect, evidence-based psychological practice, all it is an acknowledgement that the best available psychological practice at this time combines our existing evidence, the clinician's expertise, and client characteristics. So for a space of probably a decade and a half, a little bit more, when the Chambers report came out, there was a real stir about empirically supported treatments. And I know there's been a lot of frustration in the field about these terms. It went from empirically supported treatments to, it was ESTs and then EBTs, evidence-based treatments, and then evidence-based interventions. And the terms have been coming and going. But what did happen with the Chambers report that's important to note, and which makes evidence-based psychological practice an important concept, is that it really focused on evidence-based interventions. And so it was focusing on manualized treatments. And the evidence portion of this triumvirate really became sort of the most powerful part of what we were doing. The conversation all turned to empirically supported treatments, and if you were not doing an empirically supported treatment, then what you were doing had no worth. The idea behind the statement on evidence-based psychological practice, which was a document that the APA Task Force on Evidence-Based Psychological Practice put out in 2006, was to really say, hey, that's a piece of the puzzle. Yes, we have evidence. We have those zeros and ones in our data files, and we like to crunch numbers, and we like to look at how things work and don't work. But folks have clinical expertise that's terribly important, and how we apply both of those things is really going to matter depending on client characteristics. So it was a really nice move. If any of you are interested in these sources, by the way, I'm happy to share the PDFs. I have anything that I'm citing, I have PDFs for, and I'm very, very happy to share them, so just let me know. Now, the thing that is important for the context of my talk today is that evidence-based psychological practice actually exists within a cultural context itself. This is our culture, the culture of psychology. And it is important to keep that in mind, because as we are exploring ways in which to work with cultural others, or so-called cultural others, it is really important to understand that all of us are standing in a particular cultural context. And I have an ethnic cultural context, I have a religious cultural context, but I also have a professional cultural context, and EBPP is that. So what is culture? It's easy to talk about cultural context, and all of us probably have a sense of what we're talking about and that there is some common ground. But I like to put the definition out there, and the best one, or the one that I like the most, I should say, is by Hector Betancourt and Steve Lopez. It was published in '93, and it captures both objective and subjective culture. And they specify that culture are these highly variable systems of meaning, which are learned, and I bolded learned on purpose because these are important concepts for us in psychology, right? They're learned and they're shared by a people or an identifiable segment of the population. And so these are lifeways and pathways that are transmitted from one generation to another. So culture is learned, culture is collective, and culture lives on through the generations. Of course, our contexts are many. There's social class, ethnicity, religion, disability, gender, sexual orientation. Hi, Virginia. I just saw you come in. There are all of these different cultural contexts. And in terms of the culture of psychology, I'd really like to point out where it's carried, and it's certainly carried in our theories, it's carried in our practices, and in our methods for verification of what we do. In terms of practices, there are questions that I like to bring up that I think are hopefully slightly provocative. We really place a lot of emphasis on evidence-based practice. Where is the evidence for the 50-minute hour? Where is the evidence for one session a week? Where is the evidence for one provider, or that treatment must be delivered in an office setting? For that matter, where is the evidence for putting chairs at a 45-degree angle and having a box of Kleenex like this dyad here has in between the two? These are things that probably represent clinical expertise more than anything else, but that are common practices, and you can look at this picture and really recognize it as psychotherapy. If you were to say who's the therapist in this dyad, who would you identify? Anybody?
Left. Somebody, the person on the left.
The person to the left. And what makes you identify her as the therapist?
Her clothing, her posture.
Mm-hmm. Her mouth is closed, she's making eye contact, the other person is speaking. I mean, we have all these clues, right? We all can look at this picture and clearly see it. And these are all ways in which we carry this culture of psychology. In terms of methods of verification, randomized controlled trials tend to be the gold standard. We like standardized measures. And both of these things really present challenges for those of us working with ethnocultural minorities. And actually in international context, and that's a little bit different context, and I'm happy to talk about that as well. So let's go on to cultural competence. I guess I didn't want to go to cultural competence and cultural adaptations without really giving a context for what culture itself is, how it is defined, and how we carry this particular professional culture in which all of this is placed. Cultural competence is a relatively recent conceptualization, interestingly, and I was rereading my article by Sue from '98 from the American Psychologist that sort of, blew everybody's mind at the time. And it was interesting to me as I was rereading it that Sue actually defines cultural competence 3 different times in 3 slightly different ways in that same article, which I really think is just an indication of how new this is and that we're trying to wrap our head around what a definition is. And I love this muñequito. Somebody's going to have to help me. Every now and then I lose my English words. This comic that says, I'm so glad that we passed that state test, and isn't it great to be declared minimally competent? I think one of the things that it's important to put out there is that, you know, competence is something that we strive for, and we're both constantly achieving it and constantly chasing it, I think. But Sue, generally speaking, says cultural competence is the belief that people should not only appreciate and recognize other cultural groups, but also be able to effectively work with them. And that last piece really comes through in the definition. So Sue at the time was really concerned with being effective, which is part of our psychological culture, right? We want to test it. We want to make sure that we're doing good and that what we're doing works. Now, what he mentioned were the key ingredients to cultural competence, interestingly at the time, were scientific mindedness, dynamic sizing, and culturally specific elements. And for those of you that are in this literature, you probably can see where I'm going with this. Sue talked about scientific mindedness as being basically hypothesis formulation. So instead of going with clinical interpretations, observing people's behavior, and just assuming that we're the experts and that we will have the correct interpretation, it's really about checking with the person about where these behaviors come from and how they are understood by the person engaging in them. Dynamic sizing, on the other hand, is about generalizing and individualizing. So when is a behavior cultural and when is it general? And he talked about making two types of errors. One of them is assuming a behavior is cultural when it really is more general, and another one is assuming that a behavior is more general when it really is culturally specific. So he was really interested in these cognitive processes, right? We're formulating hypotheses, we're generalizing, we're individualizing. And then he said, as the third and last point, these culturally specific elements are self-awareness, knowledge, and specific intervention skills. Now, for those of you that are in this literature, you can probably recognize that it's this last point, the one that has really been developed over time and has come to be known as the tripartite model, where self-awareness, knowledge, and skills are the main ingredients for cultural competence. I like to present the notions of dynamic sizing and scientific mindedness because I think they're actually incredibly important to skills, interestingly, but it's not how it was originally conceptualized. So when I think about skills, well, let me not get ahead of myself, sorry. In awareness, we're looking at the therapist's understanding of their own biases, of their own power, and of their own privilege. And for those of you that do training like I do, you well know that this is really quite challenging, much more challenging than, let's say, building knowledge about a particular population, because you can do that by reading books, by checking in on popular media, by talking to others, but getting people to really look inward at what are your biases and how are they expressed in your everyday talk and behaviors. What is your power and what is your privilege? In my diversity class, I talk to my graduate students a lot about not only what their privilege is or what their privileges are really, but would they be willing to give them up and what that means? What would it look like if they were to give them up? And it is fascinating because it's not so easy. It's not so easy for us to consider that we have privilege, and then certainly very difficult to think about ways in which to give it up and be willing to do so. The knowledge piece really refers to a specific population, and this can look like a million different things. It could be knowing a language. It could be knowing interpersonal rules. You know, when I meet with a Latino client, oftentimes, depending on where they're from, I will greet them with a handshake or a kiss or some sort of physical touch. It's typically client initiated. It is very much appropriate within the social mores. But it is different. I have had my students say, gosh, I saw you greeting a client and I was really shocked that you touched them or that they touched you. And so those things are important and interesting in the context of what we do because, of course, it is different enough that it catches people's eyes. And then finally, skills are, the way Sue conceptualized it and the way I understand it as well, are specific intervention skills and techniques. And these could be general. I use role plays a lot, and it turns out that the Latino families I work with love them. And then we went and did role plays in Norway, and we did role plays in Iceland, and we're doing role plays in Mexico now as part of the evidence-based intervention that I work with, and everybody loves them. And so far, everybody that I've interacted with, therapists and families alike, learn through role play. So they learn through direct practice and corrective feedback. And these are the kinds of things that Sue was referring to. So who does cultural competence apply to? Is a therapist culturally competent? Is it a treatment that's culturally competent? Or is it an agency? What are your thoughts on this so far?
I'm thinking all of them.
So how would a treatment be culturally competent?
We should do some research and make sure it works.
You are exactly right. We need to do research to see if a treatment works, and that is actually exactly what cultural adaptations are about. So the way that cultural competence is defined, these two things are very connected, so they're very related, but I see them as distinguished in that cultural competence refers to therapist characteristics. It is my self-awareness, it is my knowledge of a particular group, and it is my specific intervention skills that are important in connecting with that client in a way that is appropriate. The way that we have defined cultural adaptation is actually that it refers to the treatment itself. And this was an interesting challenge because the first cultural adaptation model was actually published in 1995. But there wasn't much work done after that till the early 2000s. And part of it was that, and it still is, if you read this literature, it's really interesting. There's this, there's this kind of clumpy mess. I'm sorry, I don't know how to, translate that. But there's this like sort of clumpy mess in which we really want to do well, but there's so much to focus on that it gets really overwhelming. And so what cultural adaptations focus on are systematic modifications of existing protocols that consider language, cultural context in a way that makes them compatible with the client's cultural patterns, meanings, and values. And so we take all of that stuff that we know from hopefully being sufficiently culturally competent, and we try to apply it to these evidence-based treatments so that we can have some tools that work across the way. Partly because my guess from all of the conversations that I have had is that a lot of us are doing this work already. So we're out in the field, we're trying to put these evidence-based manuals into play, and tell you what, the concept of, the concept of respeto, for example, is not in my parenting manuals. And so it's all in the context of teaching and learning, and the parents are the teachers, and I'm working with Latino families, and they're saying, my kid is disrespecting me, and that is not okay. That sets me off. So bringing some of that stuff in, all of us that are doing this work with families or individuals, we're doing this already. And the idea behind cultural adaptations is to really give folks some support and some tools with the purpose of improving engagement, promoting retention. So are families even going to come in? Once they come in, do they stay? To increase relevance. So addressing specific risk and protective factors or symptom clusters that are specific to ethnocultural groups. Can you think of one that just falls up? I'm thinking in Spanish this morning. This is odd. Se cae de la mata. It's like, can you think of one that's like right off the top of your head? For example, for immigrant Latinos, what might be something that you would think of that are specific risk and protective factors for mental health outcomes?
family is a protective factor, you know.
Yes, absolutely. Family, and then on
family
the other
involvement in
side of
treatment.
that,
The involvement of family in treatment, for example.
the involvement of family in treatment, absolutely. So you might really set up a treatment to involve family rather than keeping it individual, right? What about a culture of stress? What about the people that leave their families behind and now they're in this country all by themselves trying to learn a new language and social customs? My goodness. I mean, that's not a small order. So things like that that are specific to the group are part of the reason why we adapt. If I'm going to conduct a parenting intervention and I'm not going to talk about respeto and I'm not going to talk about acculturative stress and how kids acculturate faster than parents, I'm missing a big piece of the picture for these families that are coming in. I can teach them techniques, but they're out of context. And that potentially impacts retention, relevant, and certainly outcomes. So we're looking to culturally adapt to tinker with these things that we know matter: engagement, retention, relevance, and outcomes. Okay. So what do we culturally adapt? We adapt the manual, but we can do it by adding sessions, we could do it by adding content, or by replacing content. So I have added content on emotional regulation, for example, but I have replaced all of the role play scenarios for parents with kids to make them more culturally relevant examples. Who culturally adapts is an important piece of the puzzle, and I think this comes from a very multicultural orientation. Yes, expert clinicians participate and expert researchers participate in adapting, but so do community members. So the idea behind cultural adaptations, if you were doing one in your community, you might actually take your manual out and say, have a couple people read it and see, does this make sense? What makes sense to you? What doesn't make sense? Give me some feedback. What can I change? So the idea behind cultural adaptations is to really involve stakeholders in a very meaningful way so that you can get as much of that cultural nuance as possible in the service of having the best possible treatment for the families or the individuals that you're working with. And for that reason, when you think about when do I culturally adapt, you're really doing it before, doing, and after. And so I remember when I was running my RCT here in Logan, Utah, we did cultural adaptations a priori. I can't take an English-speaking manual and deliver it to a Spanish-speaking population, so we translated it. That's a part of the adaptation process. But then, you know, and I had a bunch of metaphors that I grew up with. I remember my abuela chasing us around the house, screaming whatever, whatever dicho she needed to scream to get our behavior under control. So, you know, I had all this great memory of dichos. But then we went into the field and we got so much more. So my treatment manual had these huge white spaces on both sides, and we took notes at every single parent group meeting. And that manual just kept changing as we went to include more dichos, more examples, more relevant words. And then after the treatment delivery, of course, you get evaluations and you talk to people and you talk to your research team or your treatment team about what works and what didn't work. In terms of the models themselves, there actually are a ton of models. And there's an interesting thing here. I don't know how well you can see this slide. I know the letter is tiny. But there are a couple of early models. So the multidimensional model for understanding culturally responsive psychotherapies was really, it's a whole book. And this is an amazing team of clinicians. These Cosquioquino and Luis Vargas are just such deep thinkers. And the model, at the end of the day, is very difficult to put into play because it requires this like depth and nuance of knowledge that makes it very difficult. And then in contrast, you got the ecological validity framework, which was Guillermo Bernal's model in '95, which was very simple, very specific, very easy to follow. And after that, you notice that really most of these are 2002, 2004, 2006. All of these folks that from the 2004 on are colleagues of mine in one way or another. And what happened was that we were all doing intervention research. We all felt a need to develop models that guided our work. And when we looked, what we found was the ecological validity framework. So my model, for example, which was published in '04, incorporates the ecological validity framework into this broader cultural adaptation process model. But in effect, there's this many models in this short period of time because we were all working independently. And what happens is absolutely exciting to me is that when you look at these models, there are actually so many similarities across the board. So you have all of these, quote-unquote experts who are coming up with models that look a lot alike, lending much credence to the notion of a particular cultural adaptation process. I did want to show you, and I know we're short on time, but I did want to show you the most popular model, I think possibly because of publication year, but also for its simplicity, is the ecological validity framework, and it specifies 8 dimensions for adaptation. One of them is language, which is really not just, translated into the language that you're interested in, but also make it culturally syntonic. So it needs to be not just, the words need to be not just understood, but really crafted in a way that makes sense. And as you see down, it's all very, very logical and simple. You got to look at your persons. Do you have bilingual bicultural therapists? Your metaphors, do they make sense? Does your content reflect cultural values? Are the concepts consonant with the culture? Are your goals culturally congruent? Do you want to promote child obedience, or do you want to promote child's respect to the family? The intervention itself may look the same, but your goal is stated slightly differently so that it makes sense in the context that you're delivering your intervention. What are your methods? We've started using genograms in PMTO, and it's wonderful. People get really hooked. And one of the things that Sue said in that early article, incidentally, was that ethnic minority science is good science. He said there, and I couldn't agree more, that any advances that we make in any ethnic minority mental health can actually be used to inform advances in mental health, period. And so it's exciting to me over the years and being involved with this parent management training program to see that some of the things that I know work with my Latino clients are being incorporated into the broader manual. So in a Kansas statewide implementation project right now, all therapists are using genograms with their families. And it doesn't matter what their ethnic background is, and people are getting very hooked. So I should let Monica McGoldrick know, she'd be really excited. So this is the ecological validity framework. I'm happy to share any of these PDFs, either for this framework or for any of these. I have them all very handy. I do want to let you know that while cultural competence has evaded measurement over the years, cultural adaptations have not. There are now 4 available meta-analyses, and what I want you to notice here are these effect sizes. If you think about the average effect size for psychotherapy, it's a D.2. So when we say therapy works, we're saying therapy works at a D.2 effect size level. And when you look at these meta-analyses for culturally adapted treatments, we can see that they're working at really impressive levels. So the two most recent meta-analyses, Tim Smith down at BYU and Guillermo Bernal and I worked on one, and then Venish Quintana and Bruce Wampold, whose quote I showed you earlier, worked on another one. And both of these show evidence for cultural adaptations in terms of absolute efficacy, which is when a culturally adapted treatment is compared to a control. And also, Benish and colleagues showed relative efficacy, so a culturally adapted treatment compared to a treatment as usual. And both of these effect sizes are very respectable. So I think we're really not talking about a goal or an idea. We're really talking about something that has worked. And in the Smith meta-analysis, one of the things that we did find, we coded by Bernal's dimensions. And what we found was that the most effective treatments tended to be those with the greatest number of cultural adaptations, and that targeting a specific group was more effective than targeting clients from a variety of cultural backgrounds. So having a depression group for Asian adults is more is likely to be more effective than a culturally diverse group for targeting depression in adults. Does that make sense?
Yes, it did.
Oh, okay, thank you.
Yeah, I'm writing,
so
the last words.
I'm sorry, what's that?
Yeah, I was writing, so I missed actually the last sentence. Your last sentence, if you can repeat that, that would be great.
Oh, of course. So the idea, what we found, which was really interesting, was that when you target to a specific cultural groups, let's say Asian Americans or Latinos or blacks, that those treatments actually have better effect size, stronger effect sizes than the interventions that are targeted to diverse groups. So if you have a group that has Asian, Latino, Black, and you just wanted to target to an ethnic minority audience, that is less effective than if you target to a specific group. And my guess is that, when I target the Spanish-speaking Latino parents, we're getting together, we are speaking Spanish, we're relationship building about, childhood stories that are things that most of us can connect with. If I get in a room with a bunch of Puerto Ricans, the first thing we talk about in terms of parenting and child rearing is the chancleta, which is the, oh, somebody help me out. Chancleta is the, a flip-flop.
Flip-flop.
It is not, it is, I'm sorry, this is passed down through the generations. The abuela or the mom, like, chasing you down with a flip-flop was just part of our cultural upbringing. It's not part of my children's cultural upbringing. It's not something that I would pass on as an evidence-based parenting practice, but it is certainly something that we all can connect on. And that, I think that creates a different feel in a group setting, or even between a client and a therapist of the same cultural background. You could just really connect on experiences and beliefs and values. So there is a whole lot more to discuss, and I hope that you have heard in my voice how fired up I can get about these things. I find that this work is very, very exciting. I was already excited enough, and then we worked on this meta-analysis, and Benish, Quintana, and Wampold published theirs, and I got even more excited because now I know that the stuff I've been working on really works. And I just thought I'd tell you, by way of information, that actually Guillermo Bernal and I have finished a book on cultural adaptations, and part of what we did was pull people in that were doing these so that they could tell us what their cultural adaptations looked like, and then we pulled all of that work and came up with a list of recommendations that were called from all of the conceptual frameworks as well as the experiences from the folks that were doing work in the field. And really what we found is that across the board, everybody espouses the use of a systematic process. And so when I'm out in the field and I'm sort of having to come up with it, my ideas depend on how well I feel, how creative I am, sort of who I'm surrounded with. Whereas if we have these models, we can really go down point by point and go, oh yeah, I haven't thought about dichos. Let me pull that in. That'll be helpful. So everybody's really thinking about a systematic process. All of us are really focusing on ecological validity, so we want to make sure that we can generalize. We're focusing on contextualizing treatment to a cultural group. Everybody really is using, not just saying that it's good to use, but all of us are using multiple methods. You would be hard-pressed to find anybody in the cultural adaptation world that's not doing qualitative methods, for example. So we really combine qualitative, quantitative, and even within qualitative, individual interviews, focus groups. There are just really multiple methods. And finally, we haven't even touched on this, addressing the fidelity-adaptation tension, because of course within our world, one of the things that we really talk about is, are you keeping fidelity to your treatment, to your evidence-based intervention? So in terms of a big picture, I think that our evidence-based psychological practice combined with cultural competence and cultural adaptations really, I think they work well together. So if you look at the intervention itself, we can look at whether is it evidence-based and is it culturally adapted. If you look at your interventionist, is that interventionist trained to model fidelity? And is that interventionist culturally competent? The study has not been conducted yet, but I bet you that those therapists with the highest fidelity to a treatment will also have some of the highest cultural competence scores, because as those of you that train know, the people that have the deepest knowledge are the ones that are able to be most flexible with it. So that's just a normal part of learning. When you're learning something for the first time, you're very rigid about the application of that knowledge. As you move on, you become more flexible. And finally, of course, the participant, client, patient, whatever word you use, just really understanding their context. What are the risk and protective factors for that group? What is their context? What are their practices? So bringing all of these things together is quite important. And cultural adaptations and cultural competence are both a big part of the picture. So hopefully we have covered our goals, or I had covered my goals to define cultural competence, define cultural adaptations, and then really differentiate between the two in the context of a broader goal to have better access to mental health services for diverse populations while ensuring the best possible outcomes. So thank you.
As a leader in higher education, Oxford University Press is committed to broadening the ways in which faculty can share and discuss cutting-edge research in the discipline. Our Psych Talks and Cultural Psych Talks seminars showcase the authority, innovation, and excellence in the discipline. If you or someone you know would be a good candidate to lead a session, please reach out to us at jane.potter@oup.com. Bookmark our webinar site to view a schedule of our upcoming live webinars. Browse by session and sign up right on the site. To provide feedback on today's session, please visit the following link and fill out a short survey. You will automatically be entered in a chance to win $50 in OUP books from our Academic and Trade Division. Your feedback will also help us to refine our presentations going forward. And lastly, you can always visit our website to see Oxford's growing array of psychology titles. Thanks for visiting, and we hope to be able to connect with you again soon.